The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Welcome to LymphCast, episode number 6. Glad you're with us today. Let's meet our panel right away and dive into today's topic. From New Jersey, the originator of this show, physician surgeon, Dr. John A. Chuback. Greetings, Dr. Chuback. How are you today?
Hi, Paul. Good to see you. I'm doing fine. Looking forward to another interesting discussion, and hopefully I'll have another opportunity to learn. I always learn through these programs.
Definitely. So, I mean, if you're learning, just think how much more I learn as a non-physician. I just take it all in. It's a great show planned for today. From Minnesota, Dr. Mark Melin, who will introduce our special guest today. Greetings, Dr. Melin. How are you, sir?
Good, Paul. Good to see you again. Thank you. And John, good to see you as well.
Thanks, Mark. Sam.
All right, take it from there, Dr. Melin. Bring our special guest in, and let's get to it.
Thank you, Paul. I appreciate the privilege of participating. John, it's good to see you again as always, and thank you again for starting the LymphCast podcast. You know, I've heard so many positive statements from colleagues about the LymphCast, and it's making its rounds. And I just want to congratulate you and Diane again for everything you're doing for helping us to educate our colleagues in lymphedema, John.
Thanks very much, Mark. Those are nice words, and it's been a labor of love and continues to be, as you know, but I think well worth it. And to your point, I'm getting emails from people I've never heard of and have never met, and thanking us for doing this. So somehow the word is getting out, and that's good news. That makes me feel really good. Well,
and you know, you filled up through the end of this year people that are really asking to now be part of the podcast, which is wonderful. And you're already scheduling into Q1, Q2, as I understand, for next year.
Yeah, we've done very well with guests. I just hope that at some point you'll be able to contribute to the list and invite some people.
I'm going to work on it, John. But speaking of, I have been able to contribute one person today. So Ingrid Weddic.
Her name, Ingrid Weddic. Okay, good.
Is from the Twin Cities, and you know, she's I'm very fortunate to be able to send patients to Ingrid and her team over at Twin Cities Orthopedics. Twin Cities Orthopedics, she'll tell you more about it, but it's 140 plus orthopedic surgeons. It's surgeon run, surgeon administered. They have a phenomenal practice. They are locally, regionally, nationally looked to as state-of-the-art in terms of orthopedic cares. And one of the incredible things is, here's an orthopedic group. And John, you and I know that when we were going through medical school into residency, some of the smartest people we knew ended up getting matched into orthopedic residencies. But I think if we went to our orthopedic colleagues and started talking about lymphedema, they would say, lympha what? And the smartest orthopedic colleagues I know their deficiencies and know their absences in knowledge bases. And so this is where I think Owen O'Neill and the group of leadership around Twin Cities Orthopedics has said, we don't know about lymphedema. However, we know it impacts outcomes in our practice. Therefore, we're going to hire the best and the brightest and the intelligent in certified lymphedema therapists. We're going to bring them into our group. We're going to put them to work. We're going to have them see our patients before surgery, after surgery, and we're going to improve outcomes, and we're going to show the best way to do orthopedic surgery is not just a knife and joints. It's about understanding soft tissue management, and that's how we're going to improve our outcomes. So with that, I'm going to introduce Ingrid. Ingrid, this is going to be a really fun interview. and we're just going to let you do all the education. So tell us about yourself. Tell us about how you got to TCO, Twin City Orthopedics, and then let's explore what you're doing within Twin City Orthopedics.
Perfect. Well, thanks for having me. I'm super excited, and I will talk to anybody who will listen to me about this topic. So Dr. Melin and I connected on that level. I have been OT assistant. I've been working for 23 years now, actually. And I started in NovaCare, and then I was in the same building as the physicians I currently work with. And when they started their therapy division of Twin City Orthopedics, I think 12, 13 years ago now, I joined at that time. And I did primarily work in hand therapy. And then I have now gotten into more of a breast cancer rehabilitation and lymphedema route. So I took a little different spin on it, but in the last few years, we have grown our company lymphedema practice from up to, I think, 10 or 11 lymphedema CLTs now at that time. So very much expanding as we see the need and as we are trying to market this prehab approach to orthopedic care for our patients with lymphedema and swelling concerns.
So do you know of any other orthopedic practice, either locally, regionally, or in the United States, that employs 10 or 11 certified lymphedema therapists?
I personally don't. I really don't.
I've asked orthopedic colleagues, and I have yet to run it. In fact, most orthopedic practices say, what's a CLT?
Right.
I don't know, John, in your realms, if you've run into any orthopedic groups that are employing certified lymphedema therapists.
I don't know that I know here in a major metropolitan area outside of New York City. I'm sure they're here, but I personally don't know any orthopedic practices that have 11 orthopedic surgeons. Forget about 11. You know, you guys have 140 surgeons, sounds like, which is an incredible thing. The only individual that I'm aware of who's really at the cutting edge of this, Mark, is our friend in Connecticut, whose name escapes me at the moment, but there is an orthopedic surgeon who's really at the forefront of this, and we'll think of his name. But this is really groundbreaking, I think, forward thinking and really for orthopedic surgeons to be instituting such a program shows a tremendous amount of innovation and insight and really care, I think, care for their patients. So kudos to all of them, and kudos to you for this incredible program you're building. But no, I haven't heard of anything like it ever, obviously.
So Ingrid, walk us through prehab and in terms of outcome, and then walk us through those patients that get into an orthopedic practice with maybe edema and then have surgery and what happens.
Right.
So take on kind of those two pathways and why prehab is so critical to outcomes.
Well, from doing lymphedema so long, and we have many therapists who've been doing it longer than I have, you get people at their worst. You know, they've done these TKAs, these surgeries, and they come out and it's just a disaster. And so now they're in therapy for months and months and months at a time, because we not only have to address the orthopedic rehab, but now the lymphatics are shut down, all the soft tissue damage. So we have to incorporate different practices. So really introducing, you know, educating our physicians, and they're wonderful because they allow us to just come in and say, hey, we are trying this approach, and it's going to hopefully, you know, improve your outcomes. And any doctor wants to hear that, right? So I think that approaching it that way and just giving a brief education on how we think this is going to help and how we implement it. Much less therapy, honestly, you know, and as therapists, we don't want to promote that, but at the end of the day, it's the best care for the patient. So starting them, having the physicians and
I'm going to say, speaking of best care for the patient, I'm getting called by the hospital, so I'm going to walk away for 2 seconds while you're answering the rest of this question.
Okay. So, you know, basically what we're trying to do is educate the physicians and the physician assistants, the nursing staff, if you identify a patient that comes in for their general orthopedic appointment, they need a total knee, they need a total hip, they need ankle surgery, whatever the case may be, look at those, you're looking at those legs already. You're already looking at this patient. If they have signs of lymphedema or swelling, please send them to our CLT program prior to those surgeries. So give us a month, give us 6 weeks, and then, we'll get these patients calmed down enough to have a successful surgery. You go in, you get them reduced, a few centimeters even, give them proper education. This is what to expect. This is what you're going to do immediately after, and then get them scheduled to follow up with you when they can get to the clinic days after surgery. Very, very, very successful so far.
Well, that's really incredible and inspirational. As I said before, there's so much that needs to be considered. I'm just jotting notes like crazy. I'm a big note taker. Everybody knows that. But first of all, the doctor that we were dealing with, who again is a very forward thinker, Dr. Wickline, and we'll remind Mark of that when he comes back. Dr. Wickline has been working with us in providing the micronized purified flavonoid fraction, the vein formula 1000 and lymphatic formula 1000 to his patients, which I just thought it was phenomenal. When he called, we had never really considered that, and it's been very, very successful. But when looking at the patient globally, I'm very cautious ever about criticizing colleagues because it's not the right thing to do. And as Mark said, there's no question that by far some of the most intelligent individuals when we're in medical school applying for residencies are the people going into orthopedic surgery, because it's so highly competitive. So these are really, really smart people. But historically speaking, there has been a knock on orthopedic surgeons that they quote unquote stop being doctors and they become quote unquote bone surgeons, joint surgeons, et cetera. So they wind up being the brunt of a lot of teasing and ribbing, which is really just that. It really is just teasing and ribbing. It's not fair because, as Mark pointed out, they're amongst the brightest of the medical students and residents and so forth, but they do get into a very technical, specialized, mechanical field to a certain extent. So the fact that they're looking at the patient holistically is really remarkable. And we all need to be doing that. And that is one of the subjects that comes out in our program again and again. Mark, it was Dr. Wickline we were referring to earlier. Yeah. And but what I wanted to say, based on what Ingrid was talking about this preoperative evaluation and decongestive therapy and so on and so forth, a couple of things to just get the conversation rolling a little more. One of the things I've seen a lot in my practice over the years, which is interesting, I think, that it never really clicked for me until we started working with Dr. Wickline and his attitude toward managing patients prior to and after joint replacement specifically, because for years I've been getting patients referred to me who have large varicose veins in the prepatellar area, and the orthopedic surgeon wants those veins dealt with prior to having to do a joint replacement, a total joint, total knee. So I've been happy to do those cases and get those patients prepped for surgery, but we were thinking much more along the lines of hemorrhage, intraoperative hemorrhage and bleeding and so forth, that the orthopedic guys obviously didn't want to be coping with, making a linear incision right over the knee. But we weren't thinking so much along the lines of phlebolymphodema and the edema and that component of it, which was, I'm almost ashamed to admit it. I mean, it was so obvious right in front of us, and I never really thought of it that way until Dr. Wickline brought it to our attention, and now we're having this great conversation with Ingrid. So that's one of the things. And then the other thing I would say, by chance today, Anna Pizzoli, who's been on the show before, who's a physical therapist specializing here in New Jersey for many years in lymphedema. She sent the patient in consultation today, classic sort of class 4 venous insufficiency patient with edema, lymphedema that they've been treating with hands-on therapy, MLD, compression therapy, wraps, et cetera, in their place. And the patient has had some venous procedures in the past, but they were having trouble controlling the edema. They sent them to me today, and we made the diagnosis. The one leg is more swollen than the other, and they're saying maybe he needs more superficial venous treatment. And lo and behold, he had a subacute DVT in the popliteal vein. And most interestingly, he is a patient in chronic AFib. He's in his 70s, been in AFib since his 30s. He recently was switched from Coumadin to Eliquis only in the last few weeks. So it's a fascinating case. It's a little bit of a conundrum because he's already anticoagulated with Eliquis, but now I'd love to get Mark's feedback, love to get Ingrid's feedback, what they think. We're going to get him back in the hands of a good hematologist and see if maybe he shouldn't be put back on warfarin, and how else to deal with what appears to be a relatively new thrombus. He has a chronic DVT on the right side also, by the way, which was interesting. But again, to bring everything full circle, these patients need to be seen holistically. You can't just be looking at a knee joint. You can't just be looking at a varicose vein. You can't just be looking at left ventricular function, et cetera, et cetera. And this lymphatic system and edema is such a great kind of harbinger into the body for any good physician who really cares to say, hey, what's going on here? What are the answers? And is it more than just what I assume is going on? There's so many fascinating cases. So with that, I'm going to put it back to you guys, but I just had so many interesting thoughts right out of the gate.
Well, and I think that, this is an extraordinary company to work for. And with that being said, we have so much innovation, and this is just one of the areas. And at the end of the day, going back to how patients used to be treated, you had your physicians, and everybody has insurance constraints and time constraints. But when we treat that whole person, at the end of the day, we all win, and I think that working for a company that promotes that in this facet is just incredible. From our physicians all the way down, but we really do have a little bit of insight on this one.
And ultimately, as we talk about again and again on this program, the patient hopefully wins.
Absolutely. Yep.
It's all about, increasing the standard of care. And it's just so funny how this system, the lymphatic system, which has really been sort of the unwanted stepchild of medicine for so long, and to use an expression, oh, here's Dr. Iker joining us, but it's just so fascinating how central it is to so many cases and problems. Hi, Dr. Iker. Can you hear us?
Hello, John. Hi, everybody.
Thank you for joining us.
Back to the planet Earth.
Oh, good to see you. Good to see you. We're having such a very interesting discussion. Welcome.
Emily, it's so nice to see you, and welcome back.
Europe was magical, but 100 to 104 degrees. And the kids were amazing. They were singing in every cathedral, and every cathedral is up on the hill. And it was not easy to get there in such a hot temperature. But Seville was my most favorite, and besides Barcelona. Kids were singing in Sagrada Familia twice. It was really magical.
Gorgeous.
Once in a lifetime.
Well, we're so glad you were able to experience that and spend the time. So wonderful.
It's great to be back.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 246-7877 to speak to a representative today.
Ingrid, do you know Dr. Iker, Emily Iker?
Just from your shows. Yes. So yes, now I do.
Wow.
Emily,
Hi, welcome.
Thank you.
yes, Emily is a PM&R specialist working out in Santa Monica, California for many years, specializing on this very, very interesting subject of the lymphatic system. And she has her own very interesting story and has, been a lymphedema patient herself and so forth. And Ingrid, Emily is from Minneapolis, working with a large orthopedic surgical group of 140 physicians, and they have 11 lymphedema therapists working in their group to take care of patients in the perioperative period and beyond. So that's the discussion that we're into here today.
Wonderful. And perhaps we can talk after, because I see a lot of orthopedic patients with swelling before surgery, and then we do treatment prior, and then their recovery is much better.
Yes, exactly.
Yes.
Well, and that's exactly what we were talking about. And Emily, Ingrid and I got to know each other because working in the wound clinic, we were seeing some incisional wounds after surgery. And we just began to talk about what are the options to do work upstream, identify peripheral arterial disease, lymphedema, lipedema, and start treatment ahead of time, slow down the knife application of the skin to then accelerate through the postoperative period and have really enhanced surgical outcomes. And this orthopedic group, again, Twin Cities Orthopedics in the Twin Cities, has been a champion of this. And I think we can see that in the fact that Ingrid's working with 9, 10, 11 other certified lymphedema therapists within a orthopedic specific physician-run, physician-owned practice. And one of the things I was going to ask about, Ingrid, is you obviously work with an incredible patient age range. So we all think of phlebolymphodema or lymphedema of venous etiology occurring maybe in a little bit older, right?
Right.
But help us understand where in these acute injuries in younger patients, where focus on lymphatic restoration and reduction in interstitial edema can enhance outcomes in the young athlete.
Absolutely. I mean, you can see this across the board, and there might be injuries there that were pre-existing. It doesn't matter the age range as much, and we try to catch some of that, and also dealing with, you have to look again at that whole patient, and they might have had cancer, and they had inguinal nodes removed, and hence the problem. So trying to really get to the bottom of where the swelling is coming from, no matter what the age of the patient, and then treating it appropriately. And again, if we can catch them in the beginning, we're really, really trying to preach that is the best outcome for the patient. So yes, we're seeing athletes, we're seeing women, men alike. It really, there's so many different variables.
Have you had the opportunity to measure outcomes at this point? So like, guide us what was happening maybe a year, 2 years ago, and where Twin Cities Orthopedics is at this point in terms of the prehab component.
We did a presentation last fall, and honestly, since then, our numbers have gone up 56% in using the CLT services just within our company. And so it's been a huge increase. All of our CLTs have gotten a lot busier, and we've added 2 since last fall alone. And I just see that continuing to grow and expand, just to meet the needs of not only our surgeons, but also we take outside referrals from vein clinics, your wound clinic, for those same reasons, prehab, mostly care too. So I really, and I think I can say this, that our end result vision is to have a whole lymphatics division, clinic, that we have those, we're all spread across the metro area right now. but maybe to have a little bit more of a home base for our lymphatics division, just to be able to house more CLTs and get more patients in.
And the other really unique thing about your practice is you now have 3 interventional radiologists.
Mm-hmm.
You have a cardiologist. So within your practice also, now you can start, if somebody comes in with a cardiac issue, they can be seen by the cardiologist. You can perform your own duplex ultrasounds, both for venous insufficiency. You can do the in-house treatment. Again, this is a really unique model among orthopedic surgeons to look at. We need to provide, and I love the word, John, that you're using, as holistic care
Mm-hmm.
to maximize outcomes. So tell us more about your interactions with now I think Mike Cummings was just telling me you had hired your 3rd, and Rochelle Wolf,
Yep.
the other interventional radiologist.
Mm-hmm.
So tell us more about those interactions, and are you going to get into lymphoscintigraphy, or what else are you going to do in terms of workup of lymphatic dysfunction?
So basically, our company has expanded. So they have the umbrella of an eye health. So you can look that up online too. But basically, they want to have, for the patient's needs, all services available under one billable, under one roof, basically under one billing practice. And therefore, we then have access to discuss and look at patient charts with cardiology, with Mike and Rochelle at the Venus Clinic. And so we are seeing those reports. It's better communication. We can then have the same access to that patient chart, even though we are different companies. But being under that eye health umbrella has really provided our patients a lot of access to different avenues to improve their health route without jumping through so many hoops. So we wanted, they wanted to make it easier for the patients. In turn, that makes it easier for all of us. I can go upstairs and talk to the orthopedic surgeons, or if I'm down 35 miles away, I can then get online and be in touch with them too for proper communication. So I can't answer that specifically, but I do know, because eye health is growing and we're trying to get a lot of those niches under that umbrella, that I can see the lymphatics as we grow. Our lymphatics program is going to grow, and I could see that down the road to have those resources also available.
So tell us about some of the techniques you're using prehab and post-hab for maximizing outcomes.
So I wish we haven't done any research that I know of at this point. So now that we're kind of up and running and have had a good year under our belt, I do think that should be the next step for us, so we can have some good data. We could easily go back and collect some of that, but as far as I know, I haven't done any myself yet. And I don't know if TCO has. I sit on the lymphatic team, so I don't think it's something that we have brought up, but should be doing in the future, just to get, I think we would all agree that this is a very underserved population of people. And I think we all sit here today because we believe that we have the passion and we know that the lymphatics need to be taken care of, and there needs to be more people involved in that patient's care. So hopefully we'll get some research going on the TCO side of things.
Yeah, I often say, Ingrid, that I use a stronger word than underserved. I use the term neglected, and even intentionally neglected, because many physicians, not because they're bad people, again, I don't stand here in judgment of anybody, but because training has been so poor, understanding has been so limited, and the results have been so poor that basically everyone is, not everyone, but the vast majority of physicians are looking to kind of push that patient off to somebody else because they don't have the time, the knowledge, the facilities, et cetera, to cope with these patients and to help them. So it's sort of, just, maybe wear some stockings, elevate your legs, lose some weight, you're too fat, et cetera, whatever it is. And so they're not only underserved, but they're being neglected. And I think, sadly, it's an area where this is a group of patients who are being intentionally neglected because the physician doesn't have the resources or the knowledge to do anything for them. So they just sort of want to get rid of them. And
Right.
that's been
I'd
my
agree. Mhm.
Well,
Yeah.
John, for you and I and Emily interacting with our orthopedic colleagues, it's interesting because I think sometimes we don't have a good platform to go to the orthopedic colleagues, but I think Ingrid and her colleagues have a really inside track to impact orthopedic, because I think they're actually, so how would you approach that skeptical orthopedic surgeon, Ingrid, to really influence them to hit on all the things John's talking about of not neglecting the patient?
Yeah, I always start with, I'm going to get your attention by your outcomes are going to improve. Because honestly, at the end of the day, we're all here to have the best outcome possible. We all do different parts of this job, but we're all here to improve that patient's quality of life, right? So it needs to be quick and short. All of my interactions have been either face-to-face, or I'll send out a blurb like, you know what, this is what a CLT does, because oftentimes they don't even know there are 11 of us in the practice, and this is what we do, and this is what we can do for you. And basically, I don't run through the whole regime, but we're going to take measurements. We're going to figure out, based on those measurements, skin integrity, what we need to do to get that patient to reduce prior to their orthopedic surgery. When we do that, we will then follow up and track that progress afterwards. And then that is how we base our, that's where we're getting our knowledge from, right? Our outcome from. So I typically start with that. I present it that way. I have to say that, swelling, yes, people don't want to deal with it or don't know how to deal with it. So when you're dealing with swelling or lymphedema, just being able to say, hey, I can help with this. So send these patients to me. People are more than willing usually. Oh, okay, this is great, because I don't know what to do or how to do it.
Exactly.
So,
That's
yeah.
great.
Mm-hmm.
Ingrid, in a small scale, I have very similar center in Santa Monica. And because I have been here for many years, most of the physicians refer the patients, even though they don't know the etiology of the swelling. But it's pretty much word of mouth when the patient comes back to the doctor and say, look, I am so much better. My legs are much smaller. And this is what was achieved because of this and this treatment. But you pointed out initially, the most important factor is to find the etiology of the problem.
Mm-hmm.
And that's the key. And once I do ultrasound and I assess, then do I deal with lymphedema or lipedema? And then accordingly, we triage the patient for lymphoscintigraphy or indocyanine green. And then we have a network of physicians that they already know about the center. But I am so happy that you have this in one setting, and then you are triaging in very similar proximity. And the patients are going by word of mouth. The patients are going to come back and they will tell another patients to approach you. So congratulations on your work.
Thank you. Thank you.
Paradoxically and ironically, maybe, we've been going to the vein practices, we've been going to vascular surgery, we've been going to all the natural players. And maybe orthopedic surgery might be part of the answer to a national solution. And I think it's exactly to what Ingrid said is, I approach the orthopedic surgeon and speak about outcomes. And as a group of surgeons, they are so focused on outcomes because nobody wants to see a knee incision over a newly placed joint. Nobody wants to see it over an ankle. And it might be a place where we can start to have a better foothold and truly impact outcomes, because everybody's getting, they get the swollen leg afterwards and they get a duplex ultrasound to make sure there's no DVT. Well, let's start working upstream and getting a duplex ultrasound to look at chronic venous insufficiency. Let's start making the diagnosis of lipedema and helping to differentiate between lipedema and lymphedema. And let's not miss peripheral arterial disease, where all of a sudden the patient gets a total knee and now they've got a heel ulceration we're dealing with because we missed the PAD. So I really see orthopedic surgery, John and Emily, as a huge opportunity to start to educate exactly to accelerate outcomes.
Well, I agree with you.
I think they're a group that's I think they'll listen.
Well, another group that you touched on, you had a play on words that you weren't even aware of. You said we have a foothold. I think that podiatry is obviously another important area, which again is in very many cases another form of orthopedic surgery. But think about the most dependent, area of the lower extremity is the foot. And you and I have both seen over the years many problems with non-healing wounds, surgical wounds, etc., in and around the foot and ankle area. And again, this whole subject is just part and parcel to that whole discipline. So it's wide open, and the need for understanding, the need for education and awareness is just massive, obviously.
Ingrid, what do you see? So tell us about this association with the NFL and the Minnesota Vikings, because again, that's a very unique association where you have a large orthopedic practice that is wholly involved with the NFL, which is a big deal. In fact, they helped build what's called the Twin Cities Orthopedics Minnesota Vikings Performance Center. So why don't you give us a little bit of insight into this, and where does interstitial edema, injury rehabilitation, where does that intersect with lymphatics?
Yes, so we're affiliated with the Vikings, Twins, Saints. So we do have the big performance center, and I do believe it's training camp right now down there. I'm in the north, so I don't get down to that big beautiful facility, but we do have the CLTs all around, and I don't know, to be honest with you, Mark, I don't know who's treating the swelling down there, and when it comes to the teams, etc. But we do house doctors and athletic trainers, physical therapists we call it our training house. And that facility is right off of that stadium down there. And they have their own setup of equipment and all of the things that they would use for rehab, for training, for those purposes. And I don't think we have a CLT housed in that area, but that also would be a great idea as we're expanding.
And Emily, you're an expert in MLD and outcomes with acute injuries. Yeah. So it would seem like a natural fit to be able to get CLT hands on acute injuries in these high performance athletes to get them back to performance immediately, correct?
Absolutely. I am not associated with any high performance athletes. In my setting, I see a variety of patients. Just lately, I would say 50 plus, unless I see some young primary lymphedema, early onset lymphedema, and so on. But lately, I have been seeing a lot of lipedema patients. And what is interesting is that if you do a total knee on a lipedema patient, that the patient doesn't know she has lipedema, she just have a little chubbier legs, they don't heal as well. So the few orthopedic surgeons that they are surrounded in our vicinity, they are sending the patients prior to the surgery, at least a month before, and we do several sessions of manual lymph drainage on lipedema patients, and I use the compression pump treatment, and then they have a surgery. And usually how we combine it, either day before or day of surgery, they come for treatment to decompress. And then we don't see any complications after surgery, as I used to see in the past, where there was an inflammatory process going on after surgical performance on untouched lipedema patient. So there, and with this improvement, the surgeons are sending more patients when there is any etiology of swelling. And so there is a better outcome. patients are happy, and of course the surgeons are happy.
Right. And this is where Dr. Wickline is also incorporating, again, kind of, shameless plug, but this is where Dr. Wickline in Connecticut is using the micronized purified flavonoid fraction in that perioperative area as well. And I think that there's great evidence to show that would be helpful. And I know Dr. Iker has been using that in her clinic for some time with good results.
John, am I so sorry I didn't pack it with me? So I went on this trip there were 100 kids singing, and we were touring from city to city in a very hot climate. And my lymphedema really gave me a little difficulty. And I realized I packed everything for the kids, but I forgot my micronized lymph formula.
Right.
And there I saw the efficacy of the treatment with this, because on daily basis I'm taking it, and I was cruising, I was doing fine, and now I didn't have it. And I said, what is missing? Why? And it is because of the micronized lymphatic formula. And pretty much unanimously, all the patients are giving positive response to this. They have less pain and even less swelling. Mm-hmm. So please continue with this. The micronized, the lymph formula is really a beneficial, 2 tablets a day, and patients love this. And the outcome is very good.
Thanks.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
We had this discussion recently with Mark, I think on the previous program. I have this, wonderful idea that this should be available in airports for travelers with a set of knee-high 20 to 30 millimeter graduated compression stockings, and the MPFF for the duration of their trip, I think would be really valuable. But going away from that a second to what Mark was talking about, another great idea by you, Mark. As always, your mind is so active, but I hadn't thought of this either. Not only for acute injury per se, in terms of, let's say, an ACL disruption or an ankle, severe high ankle or ankle sprain, et cetera, et cetera. But what we're seeing more and more, and you're hearing about more and more with athletes at all levels, is the post-exercise ice bath. And this, right? And you've heard a lot about it with Tiger Woods recently, with the accident that he had and the injury to his leg. And after he works out, after he plays golf, there's a lot of hands-on therapy and a lot of icing. And so even this hands-on therapy would be good even in the post-extreme exercise condition for these patients, I would think. What would you think about that, Ingrid?
I think it's great. Just to piggyback on that, so I've been seeing a few like motor vehicle accidents, just being in the orthopedic setting too, where they're doing physical therapy or occupational therapy, and they can't get the swelling down. So they might have a fracture, they might have a strain. So we've been incorporating it that way too. Like, hey, we're in the building, go see our CLT. We do seriously 2 to 3 sessions, and those patients are back out there. It really increases the recovery time, and the rehab time. It just is amazing what we can do just with even acute swelling. So when you have those CLTs, that training would incorporate and encompass all of that.
And I know there's a pneumatic pump company that got involved in doing post-exercise treatments, and they got into many colleges. They're now in NHL, some NFL, some Major League Baseball as well. But that's a high pressure pneumatic pump, different than, because that's going to cause channeling in a chronic lymphedema situation versus stimulation with MLD-like to stimulate kind of in that 0 to 20 millimeter range with MLD-like with a pneumatic pump to stimulate dermal lymphatic functionality and lymphangion contractility. So this, the indication's clearing lactic acid.
Right.
with the higher pressure, correct, Ingrid?
Correct.
And
Yeah.
so
Yep.
those techniques are a little bit different and wouldn't be applicable to the chronic lymphedema patient necessarily.
Right. And we'll probably make them worse. We've had a few people buy, various pumps off Amazon, etc. And, it's what we're doing with the athlete in the muscle recovery is very different than what you would do with the lymphatics. And we all know, because we're all, lymph certified, that is just too much pressure. And it's going to actually cause a bigger problem. Again, education is the biggest component. If you can get a person in front of you for 30, 45, 60 minutes and give them the proper lymphatic education, and here's what we're going to do, and here's why, game changer.
Yeah, you would think the high pressure pumps, Mark, obviously, as you know, could potentially contribute to the trauma.
Yeah.
Right, because Dr. Olszewski, and of course Emily knew Dr. Olszewski well before his passing last year. He such a great scientific mind, and he published so many phenomenal studies, including dermal biopsies, where he showed high pressure pumps cause channeling. Well, channeling is fluid flow outside of the natural lymphatic pathway. Mm-hmm. The lymphatic pathway has, by definition, endothelial cells that produce endothelial nitric oxide, other cytokines. So that's where MLD maximizes the natural pathway of the lymphatic flow. And when we simply squeeze hard and get that channeling effect, Ingrid's hands could never squeeze at 60, 80 circumferentially around a leg. She's stimulating dermal lymphatic flow, that's where we get rid of the lymphatic stasis and bring down those inflammatory markers.
Right.
And John, you'd said before, I don't want to make a shameless plug, but I am going to make a plug for you, because I believe that in the high-end athletes that Ingrid sees, that Emily's seen, even these people, John, like you and me, that are exercising routinely, maybe just a weekend warrior, I do think diosmin as micronized purified flavonoid fraction, because of its venous and lymphatic impact, because of the impact it can have in inflammatory markers, I think daily use actually can help all of us in the long run in terms of improved venous lymphatic function and decreasing those inflammatory markers. And I will tell you, I've been taking it for a long time. And to Emily's point, when I do miss it, especially on a travel, you all of a sudden get significant negative payback. So you realize the importance of doing it. So, I always want to congratulate you and your team, John, on the effort to put forth in providing a really high valued product that is great bioavailability, great integrity in the company, and as well as it's a product that we can count on to be consistent in application. And I think that's really important, because you can go onto Amazon and buy one of any form of diosmin.
Yeah, well, the vast majority are not micronized, which is hugely important. And then, of course, all of the safety standards that our company uses. But the reason I was smiling so much about what you both said about what happens, because of course we all take it daily also. And as you know, I was just texting with Monika Gloviczki to see if she could get on the call. Unfortunately, as you said, she's traveling. But I'm not speaking out of school, because Mark, you spoke with Monika on our behalf at AVLS, when Monika said to the crowd that she and her entire family, including Peter, they take our MPFF every single day for those anti-inflammatory, antioxidant effects, generally speaking. But the reason I'm smiling is because I've had more than one patient ask me it's funny how patients, their minds sometimes work. They've asked, is it possible that the MPFF, the vein formula 1000 or lymphatic formula 1000, could cause swelling? And I said, no, not that we know of. On the contrary, it should reduce swelling. And they said, yeah, it's kind of interesting, because when I stopped taking it, I noticed that I start to swell. And I said, that's because you've stopped taking it. And they said, oh, well, that makes sense now that you put it that way. I said, that's why we put it on you and put you on it in the first place, because you had swelling. So they're making a connection between the product and swelling, but it's not obvious to them, it's because you've stopped it. They think there's some sort of, let's say, rebound effect by stopping it, et cetera. But patients see it all the time. They see the difference when they stop for a period of time.
And it's a study I would love to do with Ingrid and her CLTs at Twin Cities Orthopedic, of doing, it's actually hard for me to ethically think about doing a randomized controlled with a sham, diosmin. But I think there are very measurable outcomes that within a standard of care, totality of care, as we understand for lymphatic rehab, they could show improved outcomes in terms of reduced swelling, improved quality of life, as well as just decreasing overall wound complications. We should see decreased wounds. Now that would take, hundreds of patients, which is the beauty of Twin Cities Orthopedics, is that think about the number of patients they operate on yearly. It's really incredible. And I know some of these orthopedic surgeons very personally. These guys, so intelligent, so compassionate. I'm talking to Al Hunt last night at 8:00 at night after he and I both got out of the operating room about a mutual patient. And, the guy's, he's an incredibly caring person. So it's just a phenomenal group of compassionate people that are very, very focused, again, to your point, Ingrid, on outcomes. And so an ideal setup to talk about doing research initiatives that helps set practices apart, but also creates regional and national leadership. So I applaud your thought, and hopefully it turns into fruition about doing research.
That would be wonderful, and we'd be interested in being a part of that. As you know, Mark, I can't mention names, but there's a big group at a university hospital in Boston who's interested in doing a very similar study right now that we're working with.
So Ingrid, as we're getting close to wrapping up here, any final thoughts about your practice, what you'd like to see happening in the next 3 to 5 years, and any concluding remarks? And again, thank you for the privilege of spending time with us today. We really appreciate it.
Oh, no, thank you. This is fun. This is great. No, clearly I'm here. I do what I do every day because I see it work. And I really have a passion for figuring out the whole picture, and working with all of you to, at the end of the day, again, maximize patient outcomes, but also patient quality of life. So I would like to see I hope our practice continues to grow as far as the lymphatic pathway, those relationships with not only our group of orthopedics, but also, all of you in the vein clinics and wound clinics. And I would just like to continue hiring more people, hopefully, as we build these new clinics and get around more of the metro area, have more CLTs on site, and then even do, some off-site, you can do kind of a satellite clinic, has been in discussions too. So we can reach some of the outlying areas in the more of the rural community, and have some traveling CLT to perform those services as well. So really, ultimately, so that they're not neglected, right? They're not underserved. Patients are getting the full care that they need, and all those services hopefully under one umbrella.
And now with John's leadership, we have this great podcast to, to be able to share with other orthopedic practices. And I think this podcast alone, other orthopedics and other certified lymphedema therapists will help create that really significant leadership component. So that's where I see this as serving a great niche in closing those gaps, John. So thank you again for your leadership in creating this.
Well, it's a pleasure. And again, we go back to the basics time and time again. Mark and I both have a background in surgery. Of course, Dr. Iker had a background in surgery too before her surgical training was cut short because of her medical issue. But it starts with obviously holistic care. We always believe that a good surgeon is a good internal medicine doctor who can operate, that we're looking at the patient as a human being and as an overall organism made up of organ systems that work with one another in a harmonious way, and that good surgery should begin with good patient selection, preoperative preparation, Again, I was very sensitive to that as a cardiac surgeon, having a patient optimized before surgery. Orthopedic surgeons are very much the same. Respecting the tissues, delicately handling tissues, avoiding excessive tissue destruction in surgery, good postoperative care, wound care, et cetera, pharmacological care, supplements, hands-on therapy. All of these things come together to give outstanding results in surgical and non-surgical patient care, traumatic and non-traumatic care, et cetera, et cetera. So I certainly think that we are onto something here with this program and spreading the word and getting all of the different groups, the physiatrists, the physical therapists, the surgeons, the internists, the cardiologists, the podiatrists, the infectious disease doctors, the wound care specialists, the vascular and venous specialists, everyone getting on board, realizing that this is all a part of one cooperative effort that leads to ultimately the best patient outcomes, great savings in medical expenditure in the healthcare system, and less headaches and less medical legal responsibility for the practitioners. So everybody wins all the way around the board when this philosophy is implemented, I would say.
And I think your clinic will just grow.
Thank you. I hope so.
You're going to have more CLTs than orthopedists ultimately.
Now that Twin Cities Orthopedics is a name known by Dr. Iker and Dr. Chuback, I can guarantee you it'll be talked about. Paul,
Yes.
Well, thank you so much. Thank you. You are great. Thank you for telling us about your wonderful practice. And we hope to have you back sometimes.
Thank you so much.
Agreed. Great.
Thank you again for tuning in to LymphCast episode 6. Let's thank our panel before we leave you today. From California, Dr. Emily Iker. Thank you, Dr. Iker, for everything today.
Thank you, everybody.
And from Minnesota, Dr. Mark Melin. Thank you for all of your valuable input, but also for bringing our special guest in today.
Privilege, and thank you, Ingrid.
Yes, thanks for asking me. Appreciate it.
Yes, thank you to Ingrid Weddic. And the originator of the show, physician surgeon from New Jersey, Dr. John A. Chuback. First of all, thank you, Dr. Chuback, and any final words before we close today's show?
No, that's it. I've said all that I have to say, but thank you all from the bottom of my heart for participating. I think we're really doing something very special.
I think everybody agrees, and we thank you for tuning in today. We'll see you next time for LymphCast, episode number 7.